Welcome. My name is Sandro Galea. I serve as Dean of the WashU School of Public Health. Welcome to Public Health Ideas. These conversations aim to highlight work that advances the science of health. This, in particular, is part of a series of conversations we're having about current changes to the policy landscape. The goal is to have nonpartisan, science-based conversations, to keep an open mind about potential policy change, even to welcome potential change for the better, but to be analytic about how proposed changes may affect the health of populations. Today, I have the privilege of speaking with Professor Morgan Shields. Professor Shields is an assistant professor at the School of Public Health at WashU, where she studies the quality and accountability of behavioral healthcare. We're going to discuss the current policy conversation around mental health and substance use, its potential, and its implications. Professor Shields, welcome.
Thank you.
So let's start with the current conversation about mental health and substance use. So it feels in many ways like we're in a moment of backlash to many established approaches to these challenges, particularly in their intersection with the issue of homelessness. Does that seem like a fair characterization? And how has the arrival of a new administration influenced and shaped this conversation?
Well, first, thank you, Dean Galea, for having me to discuss these important issues. So first, I would say it's fair that the rhetoric around mental health, substance use, and homelessness has become potentially more dehumanizing and less compassionate. And we've seen a decrease in support for housing first models, supportive housing, in exchange for support around treatment first models. So treatment first, which used to be much more popular about a decade ago, is an approach to supporting homelessness where you prioritize getting a person mental health treatment or supporting their sobriety before they would qualify for housing support. Housing first flips it, and it says, actually, we are going to get this person housed first so that they can feel safe, and then once they are housed, we will work on their other goals. And so with this current administration, there's been defunding of housing first and prioritization of treatment first models. So that's true. And there's also been support for expansions in involuntary interventions. So there's treatment first, and then there's treatment first but forced. So not just voluntary, right? And so we've seen increased signaling around involuntary interventions. And there actually have been some policy changes in recent years that have expanded access to inpatient psychiatric care. But what I think is important to emphasize here is that while perhaps the support for involuntary interventions is a bit more explicit now with the Trump administration, there was increased interest in those types of interventions before this current administration, including from Democratic leaders, like in California and New York.
So this actually feeds nicely into the next question, which I had. So let's talk a little bit about defunding of mental hospitals and institutions. So defunding mental hospitals and institutions started decades ago, and there has recently been a conversation, it's been ongoing, about the ethics of hospitalizing patients against their will. Now we've seen renewed interest, and this is across the political spectrum, on the implementation of forced treatment, particularly for populations facing homelessness and those dealing with psychosis. So guide us through a little bit how we can engage with this conversation in ways that center dignity and autonomy of persons.
Okay, first I want to say, I love your question because you are anchoring values of dignity and autonomy. So often when we have conversations about mental health services and substance use services, we sort of wave our hand when it comes to the values. We say quality and access, and we're not very explicit about what we mean by quality. And so I appreciate that you're anchoring around dignity and autonomy, and I look forward to answering that. But first, if I may, can I just clarify two misconceptions?
Please.
So the first is that in these debates or these conversations about forced interventions, there is an assumption that there is some benefit to the treatment that people are receiving when they're being forced into it, right? The reality is that, shockingly, there is no evidence to support the effectiveness of involuntary hospitalization in particular on a range of outcomes: clinical effectiveness, social functioning, broad functioning. And this is important to consider because at the crux of this debate is civil liberties and human rights. And so inpatient psychiatric care in particular is one of the only times in which a person can be confined into a structure and have treatment forced upon them without their consent and without them having committed a crime. And so the assumption then is this is a good thing to do in certain situations to keep a person safe and to maybe keep society safe. But the caveat is that it should be beneficial to some degree, right? And if we don't know that these interventions even produce any benefits, then this is concerning. And it's concerning to population level health. It's not to say that individuals who experience involuntary hospitalization might not experience some benefits, but we're talking about creating loopholes around human rights that affect populations. So that's the first misconception, just to be clear, that there's a lack of evidence for its utility. The second misconception is, respectfully, I would say that there's been a reorganization of inpatient psychiatric care, but there has not been necessarily a broad defunding of it. And so what I mean by that is we used to have long-term inpatient psychiatric care in this country where people were housed. That population is much smaller now, that's true. And the role of the state is smaller, that's true. So you see people who might be hospitalized for long periods of time who are forensic patients. So they have committed a crime and a judge has ordered them to stay in a psych facility. So there's those people. And then you have people who they may be receiving benefits from the state. Somehow they end up inside of a psych facility or a nursing home, and they can't easily be discharged because there aren't community supports and there isn't housing. So you have that group, and they sometimes end up being in the state facilities with the forensic patients. So that's a population. But then most people who are experiencing inpatient psych, it's for short-term durations. So 2 weeks on average, sometimes 3-day holds. And those services are mostly provided by private organizations and increasingly so by for-profit corporate chains. And so I wanted to clarify this misconception that all the hospitals have closed. That's not true. It's just been reorganized and there's a greater role for for-profit ownership in particular. Now,
keep going. This is great.
Okay. So so on the question about, okay, so how do we center dignity and autonomy? What I would say is conceptually, a first step is actually to get consensus that dignity and autonomy are core values that should be pursued. I would argue that currently, the core values that get expressed in our system are clinical effectiveness defined as reductions in symptoms. So that's how we define success, but as well as safety and risk mitigation, and also profit, because we are operating within a market-based system. And so that is, making money is a value. And I think it's important that we're explicit about these values. And so a first step would be, okay, how do we reorient the system around values of dignity and autonomy, which is actually a pretty tall order. And I don't know how we do that. One suggestion is to try and advance this idea that trust should be treated as an outcome. And if we value trust as an outcome, as opposed to, for example, reduction in symptoms or safety, that actually creates the incentives to promote trustworthy services and the trustworthy processes. And if we anchor around that, then we would create services that people want to voluntarily engage in. And so loved ones and the system will probably find themselves less inclined to want to force a person into treatment if the services themselves are respectful and if people want to engage in them, if they're easy to access. And likely a cascading consequence of that is we will see improvement in these other outcomes that certain stakeholders are interested in, like improvement in symptoms, for example, and safety.
That's a terrific answer. Thank you. I'm just reflecting on a couple of pieces of it. We could talk about that for another hour, but the point about evidence is a really interesting and important point, right? It really reinforces the role of evidence in these conversations, and sometimes we forget about them. And the point about the reorganization of funding is also really interesting. Let me just ask an ancillary question on this, if I may, before I get to the next question. How do you address the folks who talk about involuntary hospitalization or restraint for the safety of others? How do you fit that in within the dignity framework?
Right. No, it's a great question. You know, what I would say is in the vast majority of cases in which force is used, likely it could have been prevented. and we have to think more upstream, and we have to think about relationships and de-escalation. Evidence-based models for preventing and reducing the use of restraint and seclusion and of violence within psych facilities are anchored around trauma-informed principles and relationships. It is actually evidence-based to take an approach when you see someone getting agitated, they're getting upset, to try to understand why are they getting agitated, to validate their experiences, to try and remove triggers. And so, it's really context dependent, but, I think a lot about the context of inpatient psychiatric care, and when restraint is used inappropriately, it is often because the staff they're stressed, there's not enough staff, there's all these other factors, but that they're not taking the time to build trusting relationships with the individuals. And they have sort of maybe a punishing approach and an approach that really prioritizes efficiency. There's a risk, this person's upset, let's contain the risk, let's restrain them. As opposed to, this does require allowing for there to be more risk, but as opposed to engaging and trying to de-escalate and really only using restraint as well as involuntary interventions broadly when it is absolutely, absolutely necessary. So it's not to say that there may not be a role for it in society. I think there is, but that we say it should only be in the most extreme situations, and that should be quite narrow. But in practice, I think there's a lot working against the system to actually implement a sort of a narrow definition of when to use involuntary interventions.
Yeah. So that builds nicely, I think, then to a question about community-based mental health care. So talk us through a little bit, what are the conversations we should be having? And I think it refers to the broader ecosystem, yes, academic, political, media, but also broader public, and the policies we should be embracing to help us get this issue right.
I appreciate this question. First, if I can just be honest and say that I am an academic researcher, I'm not a practitioner, and so my own experience in this world is limited to who I am as an individual, right? My own expertise. And if you were to have asked me this question a year ago, I probably would have said, well, I'm not sure, but here are some questions that maybe we can ask, and here are some directions we can go, but I don't know. But in the fall, I had the opportunity to go to Trieste, Italy. And this was organized by folks at Heart Forward LA, and they took a group of us to Trieste, and we spent a week there learning about their mental health care system. Trieste is labeled as a model for community mental health by the World Health Organization. And ever since coming back from Trieste, I've realized, there's actually very little to critique about what they're doing there, and that actually we should think about figuring out how we can implement the Trieste model and what is needed in the United States to do so. And so if I can just describe what is happening in Trieste. So Trieste has actually successfully deinstitutionalized, right? They have one psychiatric unit in the entire city of about 200,000 people. And that's about the size of St. Louis. And the unit has maybe 8 beds. And even so it exists, right? This is an example where, so yes, maybe there's a role for some, but so there's a unit. It's open doors. Their windows are cracked, and they practice zero restraint. So in the entire city, it's zero restraint. And what is key about the Trieste model is their values, and they're very values-driven. And so you mentioned dignity and autonomy. Those are core values in the Trieste model. For example, on the Department of Mental Health, they have written in Italian, freedom is therapeutic. They have pictures of the revolution from the 60s to the 80s, where there was an uprising of psychiatric patients, and they took over the psychiatric hospital, and they really pushed for deinstitutionalization. They have memorials to that. They have pictures. They talk about their history over and over again. So these values are central to how they do business. But importantly, they don't just center autonomy and rights, and then that's it. Right? That's an approach would be, you don't want treatment, and I'm going to respect you, and I'm going to walk away. They don't abandon people. They don't neglect people. They radically try to build relationships. And so if someone says, I don't want any help, go away, they might continue to try a bit, they'll respect them, then they'll come back. And they will repeatedly come back. And what that does is it demonstrates to the person, oh, maybe they really do want to help, and they are respecting my wishes. At no point have they laid hands on me. At no point have they forced me. And that is what is needed, building trusting relationships for a person to want to voluntarily engage in services. And so if I can just tell one story
Please.
about this, which is when we were in the psych unit, the director of the unit was telling us a story about how they went to someone's house and they spent 4 hours negotiating with them because they felt that actually they could benefit from going into the hospital, but they didn't want to force them. And so they spent 4 hours negotiating. And so someone in our group asked, why would you spend 4 hours trying to convince this person to come with you when you could very easily just force them? Legally, they could have, right? And she smiled really big as though it was common sense and said, why would we do that? This is the first time we are coming into contact with this person. We are building a long-term relationship with them. If we just force them, we will rupture that trust from the start, and then they're not going to want to engage with us long-term. And so it's that long-term vision and that shared responsibility of a person's journey that you see reflected at every stage of treatment in Trieste. And then also the integration of social services, housing, employment, and flexibility. Something that they say there is everyone has their own unique program. In the United States, we really love this idea of standardization. And also this is where the language of evidence-based practice gets a little complicated. Oh, this is evidence-based, so everyone should get this, or, this is a 6-month program or whatnot. But there, it's truly individualized. So it's whatever the individual needs, and not just for their mental health, but their physical health, their social health. What do they need to be happy with their life, essentially? And the social services are integrated with health services, and everyone works together, and they have shared responsibility for the person. In the United States, if I can be a little judgmental of how we do things here, it's very fragmented. It's not integrated, and this is in part because of how we pay for services. And so what ends up happening is no one person or entity has any sort of sense of responsibility for a person's long-term journey and their healing. And this is especially apparent when it comes to crisis services, where I would argue they play hot potato, and where you really see this value around risk mitigation and liability concerns, where you have someone's at risk, and so a provider tosses the potato, the patient, to the police, then they toss it to the ED, and then they toss it to the hospital. And so you don't see that sort of hot potato in Trieste. I mean, there's a lot more to say about the Trieste model, but I would say that describes its essence, and key to it is that it is values driven, and very explicitly so about patient rights.
You've answered most of this question because with the excellent Trieste example, but give me a couple more sentences about, in the US, how can we better, more effectively include the perspectives of people with lived experience?
This is a great question, and honestly, I don't know. What I could say is, what is necessary is that people who have lived experience, but especially lived experience of really marginalized situations like psychosis, forced interventions, inpatient psychiatric care, that those people actually need to be in positions of leadership. And there's a lot stacked up against people, right? There's a lot working against them. This is actually a diversity and inclusion problem to try to solve for. And I'm not sure what's the right approach to getting there, but we need people who have lived experience leading policy discussions, policy making, and leading research and asking research questions. This is important because if you think about it, there's status quo bias against people with especially quote unquote serious mental illness. And this gets embedded and reflected in clinical guidelines, in the research questions we ask, the assumptions we make. I can't tell you how many papers I've reviewed that have started off the first sentence, we need more psychiatric beds. Wow, that is filled with a lot of assumptions and a lot of implied values. And I'll tell you, someone who has lived experience might be a bit more thoughtful about some of those assumptions, or they might prioritize different questions, because the first step of the research process is to make an observation. And so if you have people who don't actually have that lived experience, you don't have those observations in the mix. So just at its foundation. So that's what I would say. We need to have people with lived experience in leadership, and then that's not sufficient. Of course, we need to have people with lived experience engaged in all of the processes in terms of practice, policymaking, but also research. How do we do that? I would say this is actually a systems problem in the same way that healthcare delivery is a systems problem. It's not an individual issue. And so I wouldn't say, oh, this is a problem that every individual health services and policy researcher needs to do a better job at X, Y, and Z. I don't think that is effective or the right solution. I actually think our institutions, the schools we're operating within, the NIH, our funders, that they need to think about how to build sustainable infrastructure to include people with lived experience and to support researchers in being able to do that type of scholarship, including incentives have to be aligned, et cetera. It's very resource intensive, any sort of participatory design. You have an advisory board, but if you want to actually co-produce scholarship with people with lived experience, that takes a lot of time. It's not very efficient. So this is like, it's actually a systems question, and I don't know specifically the answer to it, but those are like high level thoughts.
Well, I think that leads very well to my penultimate question. So you've very eloquently discussed some of the challenges with how we approach mental health, certainly in the US, but really in the majority of the world. And I think one can be perhaps forgiven and tempted to say the only solution is to tear it all down because we're doing so many things wrong. Guide me through how you think about it. How do you balance the impulse, perhaps justifiable, to tearing it all down and starting anew with the perhaps more pragmatic, more realist impulse of we have system, there is momentum, there are things that are built in. How do we make those better? I struggle with this on many issues, but on this particular issue, it seems like such a hot concern, and you've articulated it so well.
Yes. So on this topic of mental health care and the role of forced interventions in particular, and in hospitalization and psychiatry, there are entire movements of people who identify as being psychiatric survivors, which means they feel that they have survived psychiatry. That's actually quite profound to process and sit with. Yeah. It is similar to people who identify as being a cancer survivor or a sexual abuse survivor. And they have felt silenced by the establishment. They have felt, first of all, they have felt harmed by pharmaceutical companies, the overemphasis on everything is the result of your brain being bad, and therefore the way to fix it is through medications. This overemphasis on the use of the medical model to both diagnose and to treat people, and less emphasis on, for example, trauma or systemic factors, discrimination, oppression, right? These larger outside forces that shape a person's reality and can cause distress. So they feel harmed, and when they've tried to speak up, they have felt dismissed, they have felt dismissed. And so I think this is an opportunity for us to appreciate the harm that some people feel that they have had. And unfortunately, when you don't feel like you've been listened to, and when these, for example, the current administration, when people like the current administration come into power and they say, we want to burn everything down, that is quite attractive, because part of that rhetoric is a validation of the harm that people feel, and they have been wanting to be validated by people in power. And finally, they see people like RFK say things like, yes, we're over-medicalizing distress, and yes, there is an issue with the role of pharmaceutical companies in society, and that feels so good. It feels so good to have your pain seen. And unfortunately, I don't think that there's necessarily alignment in those core values. dignity and human rights, but where they are aligned is in burning it down. And so, no, I struggle with this myself. I'm very concerned about where things are headed in this country. I think that a lot of people are going to end up being hurt if they can't pay for services, defunding Medicaid, defunding SAMHSA. I mean, we're really gutting. We're really gutting things right now. So if we think about what our role is as researchers or leaders in the field, I think that this is an opportunity for us to embrace critique and humility. And unfortunately, if we don't do that, then people are going to find open arms elsewhere.
So you deal with really important and difficult issues. Mm-hmm. And you've just told us about the concern about a number of current policy changes which actually are making these issues even more challenging.
Yes.
So let's end with hope.
Okay.
What gives you hope in this moment?
So what brings me hope is actually that I see much more mainstream discussion regarding the harm of mental health services to consumers, which I think provides us with an opportunity to imagine how we might rebuild after this moment a service delivery system that is anchored in dignity and autonomy, and one in which people feel that they are receiving support, the right type of support, where they are respected, and where they don't have this desire to burn it down because it's doing its job.
You used the phrase earlier in our conversation about building a consensus.
Yes.
And I really like that phrase because I think that's what your work is moving towards. It's towards building a new consensus on this topic.
Yes, I think so.
Thank you for the work you're doing, and thank you for this conversation.
Thank you, Dean Galea.
And thank you, everybody, for joining us.